Good morning. Myself Dr. Mrinal Lakre, Assistant Professor, Department of Dravigun, Global Institute of Ayurveda. We are seeing our pharmacology series. In that series, our next drug is Bronchodilators. Now we will see about respiratory tract. In respiratory tract, majorly there is cough, cold. So all that drugs which are used in asthma or cough, they comes under respiratory tract drugs. In that we will see now bronchodilators. When there is a bronchospasm, at that time we have to use this bronchodilator to relieve the bronchospasm. Generally they are used in the status asthmaticus or in the asthmatic condition. Now bronchospasm can induce or aggravate cough. Stimulation of pulmonary receptor can trigger both cough and bronchoconstriction, especially in individuals with bronchial hyperactivity. Bronchodilator relieve cough in such individual and improve the effectiveness of cough in clearing secretions by increasing surface velocity of airflow during cough. They should be used only when an element of bronchoconstriction is present and not routinely. Their fixed dose combination with antitussives are not satisfactory because of difference in time course of action of the components and liability of indiscriminate use. Fixed dose combination of a centrally acting antitussive with a bronchodilator or with an antihistaminic having high atropinic activity have been banned in India, but many are still marketed. Some aromatic chest rubs are also used for cough remedy and locally to relieve bronchodilation. Some classification of bronchodilators. Bronchodilators are classified into three groups: beta 2 sympathomimetic drugs. In that beta sympathomimetic drugs, salbutamol, terbutaline, bambuterol, salmeterol, formoterol, ephedrine, they are grouped. Then methylxanthines. Methylxanthines, theophylline, aminophylline, cholinotheophylline. These phylline group are okay. Then anticholinergic drugs, that is apratopamide, bromide, topiramate, bromide, and etc. So now we will see sympathomimetic drugs. These sympathomimetic drugs, generally they are adrenergic drugs used for bronchodilation through beta 2 receptor stimulation. This beta 2 stimulation increased AMP formation in bronchial muscle cell, which relaxes the bronchial muscles. In addition, it increases AMP in mast cells and other inflammatory cell decreased mediator release. Since beta 2 receptor on anti-inflammatory cells are more prone to desensitization, the contribution of this action to the beneficial effect of beta 2 agonist in asthma is uncertain. Adrenergic drugs are the mainstay of treatment of reversible airway obstruction, but should be continuously used in hypersensitive ischemic heart disease patients and in those receiving digitalis. They are the fast-acting bronchodilator when inhaled. Though adrenaline and isoprenaline are effective bronchodilators, it is selective beta 2 agonists that are more now used in asthma to minimize cardiac side effects. Our first drug is salbutamol. It is also called as albuterol. A highly selective beta 2 agonist. Cardiac side effects are less prominent. Selectivity is further increased by inhaling the drug. Inhaled salbutamol produces bronchodilation within 5 minutes and the action lasts for 2 to 4 hours. It is therefore used to abort and terminate attack of asthma, but is not suitable for round-the-clock prophylaxis. Muscle tremors are the dose-related side effect. Palpitation, restlessness, nervousness, throat irritation and ankle edema can also occur. Salbutamol undergoes pre-systemic metabolism in the gut wall. Oral bioavailability is 50%. Oral salbutamol acts for 4 to 6 hours, is longer acting and safer than isoprenaline, but similar in efficacy. Because of prominent frequent side effect of oral beta 2 agonist therapy, it is reduced for patients who cannot correctly use inhalers or as an alternative adjuvant drugs in severe asthma. The dose of salbutamol is 2 to 4 milligram oral, 0 to 0.25 to 0.5 milligram IM or subcut, and 100 to 200 micrograms by inhalation. Esthalane, Crocerol, Ventrolene, Dihaler are the trade names of salbutamol. Terbutaline. It is similar to salbutamol in properties and use. Inhaled salbutamol and terbutaline are currently the most popular drugs for quick rehearsal of bronchospasm, but should not be used on any regular schedule. Regular use does not reduce bronchial hyperactivity, may even worsen it. This may be responsible for diminished responsiveness for after long-term use. Our next drug is buterol. This is biscarbamide ester prodrug of terbutaline is slowly hydrolyzed in plasma and lungs by pseudocholinesterase to release the active drug of over 24 hours. Reversible inhibition of pseudocholinesterase occurs in a dose-dependent manner. It is indicated in chronic bronchial asthma in a single evening dose of 10 to 20 mg. Bambudyl, Betadine are trade name. Then next drug is salmeterol. It is first long-acting selective beta-2 agonist with a slow onset of action, used by inhalation on a twice daily schedule for maintenance therapy and for nocturnal asthma, but not for acute symptoms. It is also more beta-2 selective than salbutamol and more lipophilic, which probably accounts for its longer action. Concern of asthma worsening due to regular use of inhaled beta-2 agonist applies to salmeterol also. Next drug is formoterol. Formoterol, another long-acting selective beta-2 agonist which acts for 12 hours when inhaled. In comparison to salmeterol, it is faster onset of action. It is used regular morning-evening schedule for round-the-clock bronchodilation. Next is ephedrine. Ephedrine, this is oral sympathomimetic, has alpha and beta-1 beta-2 action, causes mild slowly developing bronchodilation lasting for 3 to 5 hours. It is a constituent of older combination formulation and is used for mild to moderate chronic asthma. Because of the low efficacy and frequent side effect, it is not preferred now. Our next drugs are methylxanthines. Generally, theophylline and its compound have been extensively used in asthma, but are not considered first-line drug anymore. They are used more often in COPDs, chronic obstructive pulmonary diseases. Theophylline is one of the 3 naturally occurring methylated xanthines alkaloid, which is extracted from caffeine, theophylline and theobromine. The chemical reaction between the 3 is deposited. They are the compound of beverages. The source and average alkaloid content of beverages as they usually prepared. Generally, caffeine tea leaves contain caffeine and theophylline, coffee contains caffeine, then coca and chocolate contain theobromine and caffeine, and guru nuts, that is cola accumulates, which is available in Coca-Cola, it contains caffeine. So these all are contents in the. If we see this, its pharmacological action, CNS stimulate at low dose, and it stimulates heart, it relaxes blood vessels, it creates bronchodilation, it creates diuresis, urine output is increased, it increased contractility of skeletal muscle, it has some irritant action on gastric mucosa, and it inhibits phosphodiesterase and adenosine antagonism. Our drug is theophylline. Now this theophylline is well absorbed orally, rectal absorption from suppositories aeretic. It is distributed in all tissues, crosses placenta and is secreted in milk. Plasma protein bound and extensively metabolized in liver by demethylation and oxidation. Only 10% is excreted unchanged in urine. Its elimination rate varies considerably with age. A therapeutic concentration of plasma half-life in adult is 7 to 12 hours. Children eliminate it faster than at a plasma half-life of elimination is 3 to 5 hours. Elderly more slowly. In premature infants also its plasma half-life is prolonged to 24 to 36 hours. There are marked individual variation in plasma concentration attended with same dose. Generally, theophylline, metabolizing enzyme are saturable. Plasma half-life is prolonged with higher doses. The factor that needs to reduction are age, CHF, pneumonia. Adverse effect of theophylline are narrowing margin of safety, dose-dependent toxicity, and other are seen at CNS and CVS adverse effect. The next preparation of theophylline are thelong, duranel, then aminophylline are aminophylline, then hydroxytheophylline, derifylline. Derifylline, it is commonly used in asthma. It is water soluble and can be injected in IM and IV form. Then choline theophylline, it is its trade name is cholinephrine. Then theophylline anthanolate of piperazine, it can be administered in IV and IM form. Doxycycline, it is a long-acting oral methylxanthine that is claimed to not to interfere with sleep and stimulate gastric secretion. All the methylxanthines, they are used in bronchial asthma, COPDs. Now, anticholinergics. Anticholinergics generally atropinic drugs cause bronchodilation by blocking cholinergic constrictors tone. Act primarily on larger airways. Inhaled ipratropium bromide is less efficacious than sympathomimetics. Patient on asthmatic bronchitis, COPD and psychogenic asthma respond better to anticholinergics. Inhaled ipratropium, tiotropium are the bronchodilator of choice in COPD. They produce slower response than inhaled sympathomimetic and are better suited for regular prophylactic use. It's generally they are classified in natural alkaloid, atropine, hyoscine, systematic derivatives, hematropine, atropine, methonitrate, hyoscine butyl bromide, and synthetic compounds like mitretics, antisecretory, antispasmodic, vasoselective oxybutylene, and antiparkinsonian. Pharmacological action of this anticholinergic drugs, they are the action of atropine can be largely predicted from knowledge of parasympathetic response. Prominent effects are seen in organs which normally receive strong parasympathetic tone. Atropine block all subtype of muscarinic receptors. All visceral smooth muscle that receives parasympathetic motor inversion are relaxed by atropine. Tone and amplitude of contraction of stomach and intestine is reduced. The passage of chyme is slowed. Constipation may occur. Spasm may be relieved. So this was all about bronchodilators. Thank you. Now we will meet with next respiratory disease.